Hello, everybody. I'm Lisa Berkman, and I would like to welcome you to the INTREC Social Determinants of Health course. I'm going to give an overview of social determinants of health and population health today, and then over the next series of sessions, you'll learn much more in depth about each area that's really important. We hope you enjoy the course and look forward to all your feedback. So today I'm going to talk about three areas in three modules. First, I'm going to talk about population health overall. What do we mean population health, and are there frameworks for understanding the social determinants of population health? And I'm particularly going to talk about the legacy of one person, Jeffrey Rose, who was one of the first people to actually frame an understanding of what are the social determinants and determinants of population health more broadly, as opposed to understanding the clinical characteristics or determinants of health. The second module that I'm going to talk about is population health in the future, and that is related to all the paradigms we have for understanding population health and social determinants. And then the third one is going to be around specifically defining a kind of set of social determinants of health. And I'll particularly go into detail with two areas, one about social and economic disparities and social inequalities, and the second one is around social networks. So first of all, I'd like to give you a framework for understanding the way we think about population health. There are a lot of models. This is one that I like, especially because in the center you see there's a population health circle. There isn't an individual, but there's actually an entire population. And when we think about, well, what are the drivers? What are the determinants of this population health characteristic? We can think about them in three levels. First of all, there are community attributes. And when we think about community attributes, you see in one corner the social factors, which we're going to go into a lot in detail in this course. We think about cohesion, we think about social influence, networks, support, things like that. But it's also true that there are community characteristics that may also be existing at the community level or population level that have to do with biological characteristics or the built environment, housing, workplace issues, how health systems are organized. There are a set of economic conditions that have to do with employment and education. And then, of course, there are population-based, really public health programs, things that shape the water supply. What are public health programs that shape safety in the environment? And then collectively, there are a series of lifestyles and health practices: diet, physical activity, smoking. Now, obviously, these things are all interrelated in many ways, and many of them influence each other. So characteristics of the built environment can easily influence the social environment, and vice versa. So in this course, we're going to focus mostly on the social and economic characteristics, with some more attention to characteristics of place or the built environment. So that forms the first circle of community attributes. When we then move out and think about the larger context, these community attributes are shaped in part by a larger context. They're shaped in part by the natural environment in which we all live. What are the environmental conditions? They're shaped by the cultural context in which we live. So there are norms and values. And of course, they're shaped largely by the political context. So what are the public policies and laws that actually influence community factors downstream? So even though we often think of social and economic factors as upstream characteristics, they're still shaped by politics, culture, and the natural environment. And then, of course, the last circle is really that everything occurs in place and over time. So as we think about what happens over the course of 100 years, things get shaped differently. But I find this a very, very useful framework for thinking about the community contextual and place and time characteristics, which shape population health and also shape our framework for understanding social and economic determinants of health. So one of the most important things to understand, and really the takeaway message of this first introductory lecture, is that understanding why determinants of population health are so different from the determinants of individuals' health is very important. The things that turn out to drive population health can be very different. And this was articulated, I think, best by Jeffrey Rose, who wrote a very, very small book. It's about 60 pages long, on the strategy of preventive medicine. And he did this very interestingly at the very end of his career, when he had spent a lifetime doing cardiovascular epidemiology, and came to the understanding that, gosh, doctors often look at what drives individual health patterns. What is it that makes you healthy or sick? But they rarely look at what are the determinants of population health. And he gives some very, very clear examples up front. To give you an example, if we lived in a country where everybody smoked, and we only looked at that country, we would not discover that smoking causes lung cancer, because everybody smokes. If we live in a country where everybody is malnourished, or everybody has high cholesterol, or everybody drinks a lot, then it's very hard to understand what the true risk is. So the determinants of population health can be very, very different. Similarly, when we think about individual factors, there's no doubt that genetic factors play a role in individuals' risk of getting sick from specific diseases. But the evidence is much, much murkier that these genetic factors play a role in population health. So that's what I'm going to explain today, and I will give you a few examples of it. We're going to talk about the early origins of this idea of population health, because it helps to frame this social determinants approach. And then I'm going to spend some time in the second module actually talking about whether these patterns are the same in countries that are low and middle income countries, or in current circumstances today. So again, just to be clear about this, what Jeffrey Rose said is, why do some individuals have hypertension? Turns out to be a very, very different question than why do some populations have much hypertension, whilst in others it's rare. And that comes from a book that's Sick Individuals and Sick Populations, written in 1985. So to give you a very clear example of this, I'm going to show you something that I think many of you really know. It's not new. So this is the relative risk of stroke by somebody's level of diastolic blood pressure. So diastolic blood pressure is along the bottom, and then you see the risk of stroke. And you can see the relative risk of stroke goes up enormously with increasing level of diastolic blood pressure. So in shaping an individual's pattern of risk, it's very important to know if they have diastolic blood pressure of, say, 110 or over. So this is the relative risk. Now, I'm going to show you in this slide, if you look at the white bars, those are just the same points in the previous slide that shows the relative risk of stroke. But here what you see is something very different. Here you see the distribution of blood pressure in the population. So you can see that while the relative risk of stroke is very, very high, if you have a blood pressure of 110 or over, there are very few people who actually have diastolic blood pressure that high, right? So the percent of the population that has very high blood pressure is actually very small. Most people have blood pressure in the range of between 80 to 89, or 90 to 94, or even 95 to 99, in which time you see the relative risk of stroke is actually quite substantial. It's 3 or 4 times higher than people who have lower levels of stroke. So what does this mean for population health? It means that we want to think about both the relative risk, which are the white bars, as well as the absolute distribution of characteristics, which are in the yellow bars. And what this creates is a prevention paradox. So it turns out that a large number of people at small risk may give rise to more cases of disease than a small number of people at big risk. So if I just go back here, it turns out that if some large percent of the population, like 20 or 30%, has a very moderate level of blood pressure, 80 to 95, but there are many, many of them in the population, actually on a population level, they contribute more to the paradigm of more to the distribution of risk and the absolute risk for population levels than do the people with very, very high levels. So if you were a doctor and you wanted to treat a patient, you would focus on the population at highest risk, the people with 110 or over. But if you were interested in population determinants of risk, it would be much more important for you to actually focus on the large number of people who are at very moderate risk, 2 or 3 times relative risks compared to people who are 7 or 8. And in fact, you would have a larger impact at a population level if you could reduce the blood pressure of those people in those very moderate categories compared to people in the highest categories. So again, this gives rise to a prevention paradox in which a large number of people at small risk may give rise to more cases of disease than a small number of people at a big risk. So the lesson here, and the thing that I think is very important from the social determinants approach, is that the distribution of risk, as well as the relative risks, makes a huge difference to understanding social determinants of population health. So throughout the rest of this course, I want you to think of both of those things simultaneously. You should always think, well, what's the distribution of the risk? Is this a really common risk factor, or is it a really rare risk factor, as well as the relative risk? So if we live in a country where a huge number of people are poor, it makes a very, very big difference to population health, as opposed to living in a country where very, very few people are poor, even though the relative risk may be exactly the same in both countries. So the second lesson of Jeffrey Rose is that the mean drives the tail of the distribution. Now this seems very awkward when we first think about it, and turns out to be very interesting. So what he says is that the mean, that is the average, drives the tail. So when we first looked at these data, Rose wrote a paper where he compared Kenyan nomads to London civil servants in terms of blood pressure. So what we see in the dotted line is the distribution of blood pressure for Kenyan nomads. It's much, much lower than that for London civil servants, and you see the mean is shifted very much to the left for the Kenyan nomads and to the right for civil servants. And what he said is that over time, Kenyan nomads would become like London civil servants as they had increasing economic development. But you see the distribution is very different, and it involves creating a tail of the distribution, which is very much higher among London civil servants, right? So if we look at London civil servants, there are a fair number of people with blood pressures that are 160 to 200, whereas there are no Kenyan nomads who have that kind of blood pressure. So that was one of the first intriguing studies. Then he goes on to show these same kind of population distributions for another outcome. In this case, he's looking at distributions of body mass among a large number of countries for men and women 20 to 59 years of age. And again, what you see is that as the means change, the percentage of people in the tails of the distribution change enormously. So the line represents a body mass index of 30, which is very high risk, and you see the number of people who are in the tail is actually driven by the mean of the distribution. Now, what does this mean for social determinants, or what does it mean as we think about population patterns? It means a couple of things. It means, for instance, when we think about overweight, we often think about only the tails. So the rise in overweight in children in the United States, for instance, between 1960 and 1995 was huge. So the prevalence of overweight went from about 5% in the 1960s to over 14% by 1988 to 1994. And what it meant for the United States as a country is that we just focused for a minute on overweight children. We just looked at, oh my God, what's happening to all these children who are now really obese? We didn't really think that actually, as a country, we were all gaining weight. And that's actually what turned out to be true. So over this same period of time, we went from a country where the green line is 1993, the mean body mass index was 25.2, and by 2002, it became 26.5. So what happened during that time is everybody got heavier. Everybody in the United States got heavier by a certain amount, and that drove the tails of the distribution to be wildly different. What are the implications of this? They're huge when we think about prevention again, or social determinants. So for instance, it means that if we're thinking about the prevention paradox, in which Rose says, well, we should be focusing on the large number of people who are at moderate risk, not just the people in the tails. Many, many more people just gained a little weight, went from 25 to 26. And if their risk was elevated, they may actually contribute more to population disparities than actually the people who are most obese. But it also means that when we think about what's causing this obesity, what is causing this change in body mass, it isn't fair to say, well, just what happened to levels of obesity, what happened to the kids who became very, very overweight, like what happened in the United States that drove the entire population kind of over the edge? What were we all doing to contribute to this kind of pattern? And that's the difference between looking at factors that contribute to individual risk and factors that contribute to population risk. So this is a quote from Rose, and it's why we need to focus on both the means and the tails. So he says, it's commonly supposed that there is a clear distinction between normality and deviance, whether the attribute is physiologic, like blood pressure, behavioral, like eating or drinking, or social, like aggression. And the view is really attractive because it focuses attention on individuals who clearly have problems, and at the same time reassures the rest of us that we're okay. So the fact that we've all gained 5 pounds, or we're all drinking a little bit too much, or we're all hostile and slightly aggressive is not the problem. Rather, this orientation towards only looking at the tails says, oh, it's you over there. And what Rose is saying is, wait a minute, let's look at what we as a society are doing that's driving us all in this direction. So it's the moderate kind of increase in a behavior or an attribute that actually is more important. Why is a country becoming like this? Why is a neighborhood becoming like this? What are the factors that drive this large societal change? And that is actually the more important factor. So he goes on to say, if normality and deviance are indeed independent, then the normal majority are free to disapprove of the deviance, by which he means just the people who are outliers. Heavy drinkers of alcohol are condemned, but moderation is beyond criticism. Obesity is bad, but average weight is socially acceptable, even in populations where we're all overweight. In each case, the population as a whole can disown the tail of its own distribution. We can say, you're poor or you're malnourished without actually owning, as a society, this part of the tail. And that is actually the contribution of Jeffrey Rose to this. So he says, the distributions of health-related characteristics move up and down as a whole. The frequency of cases can be understood only in the context of the population's characteristics. And what he says, and this is actually one of the largest frameworks for understanding social determinants of health, is the population thus carries a collective responsibility for its own health and well-being, including that of its deviance, by which he means the tails. And that actually is the contribution of Jeffrey Rose, and why it's important to hold within us a population health perspective as we start to think about social determinants of health.